Yes, sir, you can start now.
Okay. Good afternoon, everyone. Myself, Dr. Neeraj from HiGlance Laboratory. It is my great pleasure to welcome you to the webinar. It is with great honor that I am going to introduce today's speaker to you, Dr. Abdul Hamid Jargar sir, Dr. Jamal Ahmed sir, and Dr. Raju Agrawal sir. Dr. Jargar sir is associated with the Center for Diabetes and Endocrine Care. He is a member of Vision 2035 Health and Medical Education Government of India. Formerly, he has been member of MCI and President Endocrine Society of India. Today, he will discuss on topic beta cell rejuvenation in diabetic mellitus. Dr. Jamal sir has been associated with Rajiv Gandhi Center for Diabetes and Endocrinology, JN Medical College, AMU, Aligarh, as a chairman, dean, and director. Today, he will discuss on topic glycemic control with unparalleled cardio renal protection in diabetes with SGL2 SGLT2 inhibitors. Dr. Raju Agrawal chaired the Department of Cardiology at Jaswant Rai Specialty Hospital, Meerut. This department is the biggest referral base in India for Boston Cardiac Foundation and hold the Limca Book of Record for implanting maximum number of free pacemaker in India. He will discuss on topic newer insight in the diabetic vascular disease. We would like to thank the great cadre of doctor who have faith in quality of our product. Now I would like to hand over the session to Jargar sir. Jargar sir, please start your talk.
Neeraj, thank you very much for your affectionate words, and it has been a pleasure being associated with Dr. Jamal sir for a good part of 4 decades now. Many people in the audience must not have been even born then. Amazing. It has been an amazing association at the personal level and even at the professional level. Today, in the next 20-25 minutes, I'll be talking about what is central to diabetes mellitus, whatever form of diabetes. That is beta cell. And in our younger days, when we were at PGI, Jamal Saab and me, theoretically, life used to be very simple. If somebody has type 1 diabetes, he has lost beta cells and he has got an autoimmune destruction of beta cells. If somebody has type 2 diabetes, his beta cells are reasonably okay, but he has huge amount of insulin resistance and beta cells cannot combat that insulin resistance. But over the last 4 decades, many things have happened. People have understood anterior-insular axis better, its relationship to diabetes better. People have understood how nocturnal overproduction of glucose is important. Is it related to hyperglycagonemia? Is it related to insulin resistance? People have understood better. People have understood the biology of SGLT2 receptors particularly over the last decade and a half. And people have not only understood the biology of beta cells, people have also tried to understand the aberrations of alpha cells. But what remains at the core of all forms of diabetes, including type 2 diabetes, is progressive demise and destruction and apoptosis of this beta cell. So today, in these next 20 minutes, we'll be looking at what pressures globally this beta cell is facing today, and can something be done about it? There is a global group known as Non-Communicable Diseases Risk Factor Collaboration Group, and this group has been working together for more than a decade now. We have been a part of it, looking at global data, how non-communicable diseases are globally behaving. And this is a paper that we published in Lancet, this group in 2014. And you can look at the data. We were comparing, look on the left side, 1980. When I did my post-graduation, India presumably had 11.9 million diabetics and 12 million approximately. And 2014, when we published this paper, India had 64.5 million diabetics. And in this less than a decade of a period before COVID set in, India had 77 million diabetics. And I presume by the end of this year, we will have 80 million diabetics. Now, the numbers have increased closely. But more importantly, when we are talking on that left side volume of 11.9 million diabetics, usual diabetes, when we were in the medical school, when we were doing our postdoctoral studies, usual diabetic would be 45, 48, 50, and average life expectancy was 55, 58. So glycemic burden on the body to that 11 million population would be invariably mean less than a decade. Now, when we look on the right side and we look at 64 million guys, we're not only seeing from 11 to 64 million guys. Now, a big jump of these guys will develop their diabetes in 20s, 30s, 40s. And many of them would be expected to live till 70th birthday, 80th birthday, and onwards. So not only would the numbers be increased, but the total quantity of living time in each person from a decade would be about half a century. And that would expose him to the disasters of diabetes that Professor Jamal Ahmed is going to tell you about cardiorenal protection and why that's important today. Now, if you look at it, this is another paper that our group published. It also came the same time, a month later in Lancet, looking at different body mass indexes globally. And in this particular study also, we compared the body mass index of the different populations of the world in 1975 and 2014. In 2014, Indian men and women were at position number 19 globally as a nation. 18 nations were more obese than us. But in 2014, Indian men were at position number 5. That would mean we're the 5th largest obese male population in the country. And Indian women were at position number 3. We had the highest number of obese women in the country after China and the United States. So both these things, when we talk about those 64 million diabetics or 77 million diabetics today, it means fundamentally their beta cells have a problem. When we are talking about this mammoth obesity, that as a consequence of that, there will be insulin resistance, the basic pressure will be on those beta cells. The pressure will be on islets. And that's what we are going to talk today. This is another paper our group published in 2017, October issue of Lancet. In fact, this 11th October was a World Obesity Day, and they preferentially published this paper. And this we showed that in youngsters and young adults and adolescents, obesity has increased tenfold in the last half a century. And it is this epidemic that is today giving rise to in women that polycystic ovarian syndrome epidemic. When they get married, they develop gestational diabetes. When they grow up a bit, they develop stable type 2 diabetes. When they get in 40s, they start getting significant dyslipidemia, endothelial dysfunction, and the consequences of vascular disease. And the whole show starts with the impact of this body mass on the beta cell, which is slowly caving. That will come down in the next 5-7 minutes. More importantly, this is another paper that we published in May issue of Nature, 2019. And this is a global paper. Now, initially, we thought of obesity in 90s, 80s, 90s. 80s in India, we did not talk much about it, early 90s and onwards, that it is predominantly an urban phenomenon. And then over a period of time, we thought it is a semi-urban phenomenon. Now, if you look at your data today, the rising rural obesity is driving the global obesity. Because now same Coke, the same McDonald's, the same pizza is now every small village and town globally, including in India. And the small malls in towns and tehsils is driving obesity and is getting worse by the day. And the whole brunt of all this is borne by this microorgan. small little organ known as islet. And in this islet also those beta cells that I alluded to earlier on. Nobody develops diabetes, whatever the form of diabetes, if beta cells are optimal. The mere fact that a person develops diabetes means that beta cells have caved in. Either they have become apoptotic, means either they have died, or they have become dysfunctional, even if structurally they continue to be there. And a good percentage of the beta cells is already dysfunctional or apoptotic, even at a pre-diabetic state. And the pressure on this beta cell globally, I showed you the data, is worsening every day. And this beta cell needs to be protected as much as a myocardial cell, as a brain cell. This was a very trend-setting study that was published in JCM in 2000, about 3 decades back, 1990, 3 decades back. And just look at the green one. When you look at a population whose BMI is very high, 35. Look on the left side, how that green one, how blood sugars are very high when you look at it over a period of time, 360 minutes. Give a challenge of glucose and see how it. But you simultaneously on the right side, the green, the insulin secreted is far lesser. But look in the red one. Now, after losing significant weight from 35 becoming 29 kilos per kg body weight, and 29 also is significant obesity. But look at that green, that red one. On the left side, glucose has markedly come down. On the right side, insulin has gone up. It means if you cause a significant weight loss, these beta cells can be protected. At least those which have not undergone apoptosis, which are already dysfunctional. And in the initial stages, many of these beta cells are dysfunctional and they can be retrieved. And this dysfunction is as a consequence of glucotoxicity and lipotoxicity that will come down to. If you look at normal beta cell adaptation to insulin resistance, when there is resistance, beta cells will respond by secreting more insulin. If it is sustained over a period of time, there might be beta cell mass hyperplasia. Mass may be increased. But over a period of time, if there is some form of an impaired beta cell adaptation, if this increasing demand cannot be met, there is a progressive decrease of secretion from each cell, and there's reduced cell mass. And that reduced cell mass is what we call genuine apoptosis. Progressive decrease in beta cell insulin secretion in response to nutrients is first manifested as it goes up. First manifested, when insulin is secreted, you have a first acute phase, and then you have something like the way we simulate it by giving a bolus dose or a basal dose. Then is a sustained insulin secretion. The first phase of insulin to suffer because of this thing is the first phase insulin secretion. And initially that microsecond, minute-to-minute pulsatility of insulin secretion in response to change in the nutrients is progressively blunted. It happens even before frank diabetes sets in. Are there any mechanisms available? Are there any methods available that these beta cells can be protected? Significant amount of data has been published. One of the first data was the Finnish diabetes prevention study. There was a paper published in Journal of Nutrition about 6 years back. 6 and 12 weeks of caloric restriction increases beta cell function. There was a lovely paper published in about a decade back in Diabetology that caloric restriction can restore beta cell in patients with diabetes. And a beautiful paper published in Lancet. A couple of them I would talk about in detail. Now this I have chosen in general, this Diabetology paper, but this slide recapitulates. Look on your left side. If you look at the natural history, let us look at obesity. We talk about thin fat Indian central adiposity or genuine obesity or whatever, global this thing. There's positive energy balance. That's what progressively leads to obesity. There is progressive increase in insulin resistance, and it happens over a period of not months, but years to decades, a lifelong process. And there's progressive increased fat in the liver. must have seen a so-called fatty liver, NASH, non-alcoholic fatty liver disease, ultimately leading to fibrosis and cirrhosis and hepatocellular carcinomas, plasma increase, triacylglycerol, and that unrestrained liver glucose production that I was alluding to, occurring for years. But then when it reaches a critical stage, when there is also increase in the free fatty cells, these free fatty cells are toxic to islets, particularly beta cells. And then when those beta cells start caving in, that requisite bare minimal functional beta cell is gone and diabetes sets in. And if this remains for a longish period of time, this beta cell loss will become permanent. The beta cell dysfunction will become permanent. Now, on the other hand, if you look at it, if you want to reverse it, you can do it relatively much faster. You don't need a lifetime. You can take a year or two or a few months to reduce some weight. If you look at it, if you lose, in this particular study, people lost 15 kilos of weight, negative energy balance, decrease in the liver fat. The whole cascade gets a free fatty acids. The pressure on glucose goes 24 hours. Exposure to glucose by these beta cells is lesser. Free fatty acid exposure lesser. They seem to come back to functional status thereafter. And in this particular study, they published 11 patients with type 2 diabetes mellitus, who on an average had 4 years duration of diabetes, 600 kilocalories for 8 weeks, normalization of blood glucose in all, improved hepatic insulin sensitivity in all, improved plasma first phase insulin response in all, and reduced pancreatic fat. So the point is, yes, it is doable. In a similar study published half a decade back in Lancet, we showed, this was conducted in Britain. It was an open label cluster randomized trial at 49 primary care centers in Scotland and England, where, weight management program was the intervention arm, structured weight management and best practices by the guidelines. This was from younger to older people who had recently been diagnosed with diabetes. All of them had diabetes of less than 6 years duration and BMI of 25 to 46. And those people who were in the intervention arm, 24% lost 15 kilos of weight. And diabetes remission in the intervention arm was 46%. Half of them did not need any pharmacotherapy for more than a year, whereas it happened only in 4 people in the comparator arm. So in a similar fashion, in this particular study, where people looked at progression of overweight pre-diabetics to diabetes, and they gave a structured 2 months medically vetted energy drinks to reduce weight, to reduce calories. All those in-home calorie restriction were done. You can see probability of not getting type 2 diabetes during the observation period was decreased by 96%. So again, if those measures are taken early, probably we can expect those beta cells to be retrieved. This is an Indian study, a short study by Anjali and Unikrishnan from Pune, where, on 3 months restricted diet, look at the hemoglobin A1C of 9 dropping down to 6.2. And even though it was a relatively smallish study, 12 numbers only, half responded very well, half did not. But conceptually, it means that, yes, it is doable. GLP-1 is a growth-promoting hormone for beta cells. It promotes their growth. It promotes their survival. It promotes their replication. So GLP-1, its analogs have a potential of increasing the pancreatic weight and beta cell replication and mass. A lot of studies available in animal world where, a decrease in GLP-1 has been shown to cause apoptosis of beta cells and the reversal. And you can look at this similar data published in endocrinology 20 years back, and it's published in diabetes. You look at those pinkish cells in the mice diabetic pancreas, those are the apoptotic cells. And on the right side, that is a normal diabetic pancreas, very few apoptotic cells. And in the middle are the diabetic cells exposed to DP4, where GLP-1 has been stored. So you see those pink cells have dropped down significantly. So if looked critically, there are mechanisms available that can help us in protecting those beta cells. If not cyanide, at least for a longer time. And similar data available with the liraglutide and metformin. Look on the left side. Early insulinization, huge amount of data. If you give very early insulin, establish a hemoglobin A1C of 6.5 or lesser, in significant number of people, you can achieve a euglycemia. Data available, published, quite a couple of dozen studies published in different forms that, yes, people have given this insulin from 3 months to 1 year and have ensured that they achieve a hemoglobin A1C of less than 6.5. And in fact, in some studies, even 6. And then they could quantify that beta cell activity was really normal, and most of these studies showed that a euglycemic state could be maintained without pharmacotherapy. All of us know about bariatric surgery. If you do it in time, if you do in people who have a morbid obesity and diabetes, we expect a diabetic remission from 80 to 90% of the people. So there are strategies. The biology of this needs to be better understood. We don't have time to get into the details of that, but again, it's doable. So in summary, this is what is at stake, the islet cell. What are the different ways in which this beta cell can be revived? Ensure self-replication, neogenesis from precursor cells, neogenesis from circulating stem cells, and all epithelial mesenchymal cells getting converted into pancreatic beta cells. All these have been tried successfully. And reprogramming, transdifferentiation. If you just look at this, data available in, the first paper published more than 2 decades, almost 1.5 decades back, in Proceedings of New York Academy of Sciences, converting a hepatocyte into a beta cell, into a functional beta cell. Look at this paper in Nature, converting an pancreatic exocrine cell into a beta cell. And low below, look at the paper that was published last, an alpha cell, which is normally supposed to produce glucagon. Reprogram to convert it into a beta cell to produce insulin. In fact, Rajiv, there was a beautiful paper published last month about COVID, where, apart from what COVID does to islet cells, destroying them, there's a small number of people where it goes into the genome of beta cells and converts them into the alpha cells. So instead of making insulin, they start making glucagon. That seems to be happening because of the COVID virus. So in summary, type 2 diabetes mellitus fundamentally is characterized by progressive loss of beta cells, whatever the magnitude of insulin resistance. Unless that beta cell fails, most of the people with insulin resistance may not develop diabetes. But most of the people with type 2 diabetes will have beta cell failure and insulin resistance. The rapid rise in rates of type 2 diabetes equals similar rise, as I showed you the national and global data, increase in the obesity in all tiers of the population. Interventions that reduce body fat, and I told you, that body fat, how in particular, the fat in the pancreas, the fat in the liver, have a deleterious effect, and how GLP-1 receptor agonists, and if there is an anterior insular axis defect, decrease in the GLP-1, and GLP-1 being a trophic hormone for the beta cells, if that is an inadequate quantity, that will also promote a functional deficiency of beta cells, and beyond a point, a structural deficiency. So many of these interventions should form the basis of interventions to prevent and treat type 2 diabetes mellitus very early, so that whatever beta cells are left behind, they could be protected and kept in functional state for as long as possible. Thank you so much. And welcome, my friend, Dr. Rajiv. Any questions and queries, all yours, sir.
Thank you, sir. So,
Good afternoon, sir.
good afternoon. I'll just run through and let me say I am audible.
Yeah, you are.
Yeah, yes.
So I'll share. It is always pleasure to listen to Dr. Jamal and Dr. Hamid Zargar because my interests are selfish. Learning diabetes from them means you can understand the vascular injury better in diabetes. So I am thoroughly impressed with the kind of concept you gave me about beta cell regeneration, transition, and in the last COVID transformation of beta cell to glucagon. That means the epigenetics do transform these cells into different cell groups and add to the injury or add to the problem. There is a huge connect between diabetes and vessels. And going on further, taking the baton further where Dr. Zargar left, the beta cell of mesenchymal region, my cell, the endothelial cell, also originates from mesenchyme. The fat cells also originate from mesenchyme. In the presence of inflammation and insulin resistance, there is role reversal. By this I mean the fat cells also transform beyond storage to the endocrine gland start secreting different humoral substance reversal in hyperinsulinemia and insulin resistance. And that's why we have to partner with our diabetologist colleagues to learn from them the mechanistics, and that is how we can work better on vascular endothelium. I am just going to rush you very few things which are very tempting and has happened in last couple of months. And I always say the face of Janus, it looks to forward and it looks backward or the present. And similarly, every information in diabetes is double-faced, microvascular, macrovascular, insulin sensitizer, insulin secretory box, investing today, earning tomorrow, looking at the glycemic looking at the vascular protection. This is very, very recent, which has come and talks about the re-amputation with diabetes, and you'll find in 6 years, roughly about 40% of patients will have another amputation, those who have an amputation in the contralateral limb or in the same limb, meaning thereby diabetic atherosclerosis never sleeps. It may be silent, but never sleeps. Another good piece of information is gestational diabetes, which looks so innocuous, but translates into future heart failure. So when the patient of gestational diabetes come to you, their diabetes disappear, but never forget, they have 62% higher risk of developing future heart failure. Sleep disorders with type 2 diabetes associated with health outcomes. You can have insomnia, obstructive sleep apnea, restless leg syndrome, and newly described entity of circadian rhythm, sleep-wake cycle disturbances, CRSWDS. And remember this slide, I'll talk to this slide again in the end. This slide is also associated with these kind of activities like pro-insulin-like molecules. Insulin resulted in pi expression and resulting into more thrombosis. And you have circadian variation, and that's why the vascular events are more in the morning. High sugar results in increasing cholesterol in infants because high sugar means high insulin, and it upregulates the genes for PCSK9, resulting in faster degradation of LDL receptor and leading on to LDL rise. So in a way, hyperinsulinemia also accounts for higher cholesterol because of degradation of LDL receptors, because of upregulation of PCSK9 gene. Micro and macroangiopathy, they coexist. Macroangiopathy precedes microangiopathy, and those who have retinopathy have higher number of vessel involvement, maximum stenosis is more, and they have bad scores. Gemini scores are more depicting higher disease burden. So retinopathy, once you see, never forget macroangiopathy, and even microangiopathy is affected by statins. You can see the cumulative incidence of diabetic retinopathy decreases, cumulative incidence of proliferative diabetic retinopathy decreases. So statins also work on microangiopathy. The microangiopathy where Dr. Zerger left, even with bariatric surgery, microangiopathy is being benefited. HFpEF is a known entity in diabetic overweight individual and otherwise also, and roughly 68% of these people will have HFpEF in spending 5 years in type 2 diabetes mellitus. Epicardial adipose tissue is another problem, is associated with cardiac dysfunction. In fact, epicardial fat is associated with more HFpEF and RV dysfunction, and you can measure it on CT scan, which looks very innocuous. The outcome of these 4 patients is different depending upon epicardial adipose tissue. Keep in mind. And again, in diabetics, long-term major outcome in MACE is associated with epicardial fat. Another thing which has come very, very recently, I think about not even a month back, triglyceride glucose index. Just multiply triglyceride into glucose into fasting level and divide by 2. That gives you triglyceride glucose index, which is a very, very strong independent indicator of myocardial ischemia. When they considered and compared with LDL, with angiographic stenosis and SPECT, they found triglyceride glucose index is superior to LDL, to ischemic burden on CAG and SPECT imaging. That means the glycated hemoglobin is another way to pick up the subclinical atherosclerosis, and you can find out at lower level where euglycemia is there, but you have higher glycated hemoglobin. In fact, these patients are what Dr. Croft described as diabetes in situ. These are the patients who are normoglycemic but have higher glycated emissions into consideration in long-term management of subclinical atherosclerosis. The newer way to look at trials is not MACE, this is called MARS, because the newer drugs like SGLT2 inhibitors have given us a new understanding that not only renal and cardiac outcome, both should be considered. So maybe in times to come, we start talking of MARS in relation to drug, like we in 2008 started talking of CV outcomes in anti-diabetic drugs. Similarly, it is the new beginning. Remember 2020 that now the future outcome trial will consider MARS instead of MACE. Coming back to sleep cycle, which I showed you, the 2020 proposal for health, and in relation to diabetes, it talks of promote proper sleep hygiene. So that is one thing where I focus on you, that try to understand the sleep disorders in diabetics, diabetic vascular health, and teach your patient to learn proper sleep hygiene, which is a very good understanding, new understanding in management of diabetes. Last slide is ischemia trial, coronary artery disease, and when in relation to diabetes, one thing is consistent, that in diabetic patients who are asymptomatic, management of vascular disease is aggressive risk factor management. Don't confuse it for interventions and aggressive intervention in asymptomatic diabetic vascular patients. Even today, in September 21, we hold the same dictate and dictum that chronic coronary syndrome in diabetes, there is no incremental benefit with interventions. The aggressive medical therapy continues to be the direction given to us by guidelines. Whatever you spend today result in incremental return, because you are going to spend a lot of time with diabetes now. The life is prolonged. So never think of investment in terms of newer molecules like SGLT2 inhibitor or a GLP-1 receptor analog, because you will get return in terms of less hospitalization, less vascular injury as the life is prolonging, and the money you invest will return with good yield. In the end, I'll just summarize. Diabetes means diet and exercise. Never forget these two basic foundations. They will never change, and never forget, never be drifted by newer guidelines, newer drugs. They will never ever replace a good old advice. Walk and control your diet. View of diabetes is to be changed. We have to look diabetes in a different perspective altogether and understand the mechanism from our experts in diabetes like Dr. Zamil and Dr. Ahmed and Dr. Zerger, and translate them into a vascular perspective and give our patient a holistic care. Thank you very much.
Thank you, Raju sir. Now I would like to invite Jamal sir to start his topic on glycemic control with unparalleled cardiorenal protection in diabetic with SGLT2 inhibitor. Jamal sir.
Yeah, just.
Yeah.
Is it visible?
Yes, yes, sir.
So thank you. Really a beautiful deliberation by Dr. Rajiv Agrawal. And he told one thing about the vessels which are involved, and this is the particular endothelium, because endothelium is one of the cells where probably it does not require the presence of insulin 20 inside the glucose inside the endothelium cells. And this is true what Dr. Rajiv has said, that if you have somebody has amputation of one limb, within 5 to 6 years you'll have amputation of other limb also. That shows that how this disease is affecting the endothelial cells of the body, which is one of the largest endothelial gland in the body. This also published data that somebody has got amputation, his life expectancy is reduced to 50% after 5 years. And around 50% of these patients, in fact, they die if they got history of amputation. And that simply reflects the vascular environment. So thank you very much, Dr. Jigwa, always, and you brought so many things here and some very important information. And you said rightly that the lifestyle modification, that means diet and exercise, will never be replaced by any invention whatsoever they are there. So I'll just today talk about the glycemic control with unparalleled cardiorenal protection for people with diabetes, and with a focus on SGLT2 inhibitors. So some of these portions I just mentioned, what is the problem with the diabetic management in the Indian scenario, what are the diabetes and cardiorenal complications, the latest guidelines, the SGLT2 inhibitors, and the recent trial with some of the SGLT2 inhibitors, starting from the EMPIRE outcome, EMPIRE reduce, and some of the trial under glyphosate. So this is the real problem here. If you see the our country, what is the variation in the health system performance of managing diabetes among various states in India? And this is just a cross-sectional study of individuals with aged from 15 to 49 years. And if you just see here that only 53% of diabetic people, they are aware they are suffering from diabetes. Unawareness is to the tune of 47%. 42% patients, they are being treated. Untreated patients are 58%. Only less than 25% people, they are controlled. That means they've got HbA1c of less than 7%. And still 75% people, they have got uncontrolled diabetes. So you can see that there are the larger losses to diabetes care at each step of the cascade in India, with the greatest loss at the awareness and treatment stage. That means 75% people, they are uncontrolled as far as the diabetes is concerned. Now, some of the portion Dr. Raju has already mentioned here, but I'll just say that this is the what you call the prevalence of cardiovascular disease in patients with type 2 diabetes. We know that at the time of presentation of type 2 diabetes, 1/3 of the total patients which we see in day-to-day practice, they have got some form of the uh, vascular disease at the time of presentation. And this is just numerical fact that one in 3 patients with type 2 diabetes have known cardiovascular disease. CAD occurs 1 in 5 patients, heart failure in 1 in 7 patients, and MI in 1 in 10 patients. As for the subclinical cardiovascular disease is concerned, the 2 in 3 asymptomatic patients with type 2 diabetes, they have got subclinical cardiovascular disease. Significant CAD is present in 2 in 5 patients. Subclinical heart failure in 2 in 3 patients. Subclinical atherosclerosis 2 in 3 patients. And pulseless lower limb 1 in 8 patients. Now, there are about 68% of the asymptomatic patient of type 2 diabetes, they have got subclinical heart failure as by demonstrated by resting echocardiography. And this is just a small study, cardiac phenotypic study, and where 161 asymptomatic patient with type 2 diabetes with the mean age of 59 were assessed. And you can here see on your left side, systolic dysfunction was present in 31% of the patient, diastolic dysfunction in 44% of the patient, and structural abnormality in 27% of the patient, though these are the patients who are absolutely asymptomatic. Now, my focus will be what's important role of SGLT inhibitors in some of these cardiorenal continuum process. And if you see the SGLT inhibitors, they are basically they are affecting at the level of kidney. They increase natriuresis, increase diuresis, increase glycosuria, and decrease intraglomerular pressure. That means they will reduce the cardiac preload. And then again in the heart, they will increase the metabolic efficiency, increase oxygen supply to myocardium, decrease oxidative stress, decrease fibrosis, decrease epicardial fat, and decrease neurohormonal stimulation. And this will give rise to increase in the left ventricular diastolic function and decrease in the left ventricular mass. And then the SGLT inhibitor also will improve the endothelial functions, decrease the arterial wall stiffness, and decrease vascular resistance, and thereby they will reduce the cardiac afterload. So you can see that basically there are 3 important functions of SGLT inhibitor as kidney, the heart, and the vascular system is concerned, that they will reduce cardiac preload and afterload. At the same time, they will improve the left ventricular function, left ventricular diastolic dysfunction, and decrease the left ventricular mass. So these are some of the chronic complications in newly diagnosed type 2 diabetic patient. And here you can appreciate here that 54% of diabetic patients who attend medical OPD for the first time were found to have proteinuria and elevated serum creatinine. And you all know that the albuminuria is one of the markers of vascular disease in both in diabetic as well as non-diabetic person. Now, the type 2 diabetes, cardiovascular, and renal complications are interconnected, and Dr. Rajiv has said that in future, and now we'll talk about the not only maize, but talk about beyond maize. So we'll talk about the drug which not should give rise to glycemic control, glycemic variability, but it should also reduce the cardiovascular renal complication. So both the cardiovascular and renal complications are interconnected. And you can see here on the left side, 35 to 45% of the patient with heart failure, they have got CKD. 20 to 40% of the patient with type 2 diabetes have CKD, and 76% of type 2 diabetic patients have CKD and CVD, cardiovascular disease. 12 to 45% of the patients with heart failure have diabetes, and 10% of the Indian population has diabetes. 32% of the patients with coronary artery disease have type 2 diabetes. So what are the recent guidelines for the diabetic management? I am sure we all are aware. This is the guidelines for the that was published in Diabetes Care 2021. And the latest ADA 2000 guidelines include a dedicated decision pathway for CKD and heart failure, meaning thereby when you're treating patient of type 2 diabetes, you must have assessment for both the chronic disease as well as the heart failure. And now there are two, you can say that three important SGLT inhibitors. So talk about DAPA and canagliflozin. These are the two SGLT inhibitors. They have got primary renal out data. And talk about DAPA and empagliflozin, they have got primary HF outcome data. So therefore, you can say that in patients with type 2 diabetes and established heart failure with reduced ejection fraction, SGLT inhibitor with proven benefit is recommended to reduce the risk of worsening heart failure and cardiovascular death. Now, this is again the standard ADA guidelines, and I'm sure it may not be visible. It's not very difficult to remember also. So what these guidelines say that if you see a first time a patient of type 2 diabetes, of course, apart from the lifestyle modification, the metformin remains the first line of therapy. And then you must have at least must look on the three important aspects. Is this patient have got established atherosclerotic cardiovascular disease, or the person have got markers of atherosclerotic cardiovascular disease? And the markers of atherosclerotic cardiovascular disease is that if the age is more than 55 or 56 years, if the person has got LVH, or if there are more than 50% carotid arterial stenosis, these are the markers of atherosclerotic cardiovascular risk factors. So here, once we type 2 diabetes, where we have already started metformin, but if the person has got established cardiovascular disease or have got a marker of atherosclerotic cardiovascular disease, the first line of therapy is either you choose GLP-1 receptor with proven cardiovascular benefit, or you prescribe the patient an SGLT inhibitor with proven cardiovascular benefit. Now, irrespective of the baseline HbA1c. Now, if the person has got heart failure, then again, you have already started metformin, but irrespective of your target or irrespective of HbA1c, if the person has got heart failure, then of course you will, and particularly the heart failure with reduced ejection fraction, that means ejection fraction is less than 45%, then SGLT inhibitor should be prescribed. Now, if the person has got CKD, and again, irrespective of his baseline HbA1c, and again the SGLT inhibitors become the drug of choice. Now, if the person at the time of diagnosis does not have indicators of high risk established cardiovascular risk factors, CKD or HF, then, and if you have already started metformin, if the HbA1c is above the target, then you can have addition of DU4 inhibitors, GLP-1 receptor agonist, GLCL2 inhibitor, glitazone. And when the cause is factor and none of these established atherosclerotic cardiovascular disease or factors are present, then of course you can choose the sulfonylureas or glitazone after metformin in order to achieve the desired target. And this is what the simple guidelines have been educated by American Association of Endocrinologists, that at the time of diagnosis, of course, everybody will stress on, and what Dr. Raju has said, that no guidelines or no form of the recommendation will ever replace diet and lifestyle modification. So, of course, apart from giving lifestyle recommendation, if at the time of entry HbA1c is less than 7.5%, then of course you will start with monotherapy. Will it be metformin, SGLT inhibitors, and the GLP-1 receptor 2 agonist? And when you talk about anywhere, you talk about GLP-1 receptor agonist or SGLT inhibitor, look for the presence of established cardiovascular disease, atherosclerotic cardiovascular disease, or CKD stage 3, or the person has got reduced ejection fraction, then irrespective of HbA1c, you will choose one of these drugs. And at the end, if the HbA1c is more than 7.5 but less than 9%, we'll start with dual therapy or triple therapy. And if the NT-A1c is more than 9%, then of course, if the person is asymptomatic, then you start with dual therapy or triple therapy. And if the person is symptomatic, then insulin becomes one of the choice for treatment of these patients. Now, this is the treating algorithm for selecting anti-hypoglycemic for patients with type 2 diabetes. As I mentioned, lifestyle therapy is the cornerstone, and this should be stressed at each and every visit of the patient to the physician. Of course, the first line therapy is metformin, but remember that if the eGFR is less than 45, then metformin dose should be reduced. If the eGFR is less than 30, it should be discontinued. And of course, in the stage of dialysis, you will not use metformin. And if we talk about the SGLT inhibitor, then eGFR should be more than 30 if you are using DAPA, and if you are using EMPA, standard recommendation is that eGFR should be more than 45. And addition, the therapy is required, and for needed glycemic control, whether D4 inhibitors, sulfonylureas, and insulin or glucagon, depending on the situation. So some of the things I just go quickly. What is the new era of SGLT inhibitors? That's a boon, really boon for diabetic. And here you can see this is the EMPA-REG outcome. And it's important, the EMPA-REG outcome you already shown this. It was published, I think, about 7-8 years back. And in the EMPA-REG outcome, we showed that this was done in patients with type 2 diabetes who are having high risk for cardiovascular events or established cardiovascular disease. And this was 1:1:1 randomized control trial where more than 7,000 patients were involved. And the duration of trial was 3.1 or 3.2 years. And the primary outcome was assessed, and it was shown in this trial at the end of 3.1 years that the primary outcome, that is cardiovascular death, myocardial infarction, and non-fatal stroke for empagliflozin, was 10.5 in the EMPA arm and 12.5 in the placebo arm. So again, the glycemic control in the superiority trial, of course, we have seen in this trial that as compared to placebo, there was a significant reduction in the HbA1c. The cardiovascular deaths were reduced, and so you can say that this EMPA-REG outcome conclude that a SGLT inhibitor is superior to placebo in improving glycemic control and reducing the cardiovascular events in patients with type 2 diabetes and established cardiovascular disease, including mortality benefit. So much so can say that reduction in the primary outcome was to the tune of 38%, 35% was for the reduction in the heart failure, and 32% were of a reduction in the mortality. And this was one of the first large-scale type 2 diabetes trials to show an improvement in the heart cardiovascular outcome with simultaneous improvement in the glycemic control. So in the post-hoc analysis, you can see that the significant benefit of empagliflozin for cardiovascular death was evident on day 59. You can see that with the red line here, that on day 29, it showed that the benefit in terms of reduction in the cardiovascular death on day 59. And again, it was also known in the post-hoc analysis that significant benefit was also there for heart failure hospitalization on day 17 onwards with the empagliflozin. And again, this showed that there was a significant benefit of empagliflozin in cardiovascular death or hospitalization in the heart failure outcome on as early as from day 27 onward. You can appreciate with the red line. And then we have got imperial reduced trial. That means here the effect of empagliflozin was assessed on cardiovascular and renal events in heart failure with reduced ejection fraction. And here you can say that what was concluded that in patients with chronic heart failure and reduced ejection fraction, imperial reduce achieved all three endpoints, whatever I had mentioned, and the 25% decrease in the risk of composite of cardiovascular death and heart failure hospitalization observed in imperial reduced trial was identical to what seen in the DAPA-HF trial. Although the effect of cardiovascular death in impaired reduced was smaller than that seen in the DAPA-HF trial, the reverse was true when the effect of dapagliflozin and empagliflozin on cardiovascular death were assessed in comparative trials in type 2 diabetes. Taken together, we believe that concordant results of DAPA-HF and impaired reduced should be sufficient to establish SGLT inhibitors as a new standard of care for patients with heart failure and reduced ejection fraction. And now, this is if you just see there are certain points here and compare the various SGLT inhibitors, you can see you start from the left side. The first one is for the risk reduction, and then the cardiovascular death risk reduction, and the all-cause mortality, the hospitalization for the heart failure, and the kidney outcome. You can see that top on the EMPA reg outcome trial has shown the significant benefit in terms of the relative risk reduction, the cardiovascular death risk reduction, the all-cause mortality, and the hospitalization for the heart failure and chronic kidney outcome, like 14, 38, 32, 35, and 46%. And if you declare TB58, we don't have any data on that shown in DAPA declared TB58 to show that any benefit on the major adverse cardiovascular events or cardiac risk reduction of cardiovascular death and the all-cause mortality. There was no impact, but the effect was mainly in terms of reduction in the hospitalization for heart failure to the tune of 22%, and the chronic kidney outcome was 45%. CANVAS program again has shown the benefit in the hospitalization for the heart failure and kidney outcome, and the VERTIS CVTAL also showed the benefit on these 2 points. But the last 3 ones, the 3 trials, DECLARE, CANVAS, and VERTIS, they have not demonstrated in the risk reduction of the cardiovascular death and all-cause mortality. Now, the SGLT inhibitor, that SGLT inhibition reduces the renal glucose reabsorption, and thereby they increase the glucose excretion. That's one of the major mechanisms of SGLT inhibitor. And another that is important is SGLT therapy is predicted to be renoprotective by reduced RAS signaling. I mean, this is one of the very important actions of SGLT inhibitors, and why this drug is reducing the albuminuria and reducing the progression of chronic kidney disease. Because you know that one of the earliest abnormality in chronic kidney disease is the tubular feedback mechanism, which is defective. And you know that around 40% patients of type 2 diabetes, they have got chronic kidney disease. So this, because of the restoration of tubular feedback, they are basically responsible for giving all the important action. Say, like you can say that in diabetic person, there is afferent arterial vasodilatation and efferent arterial constriction. And this is responsible for increased intracranial pressure, increase in GFR. And when you use SGLT inhibitors, then they will give rise to afferent arterial vasoconstriction, and efferent arterial is not affected. And thereby, they will decrease the intracranial pressure, they will reduce the hyperfiltration, and they will respond for the normalization of the glucose. At the same time, uh, they will also give rise to natriuresis and increase delivery of sodium to the juxtaglomeralar apparatus. So this is the way that the renal protective effect of SGLT inhibitors is evident. They also modify several cardiovascular risk factors by many diverse mechanisms. Some of them we already mentioned by Dr. Raju here, but basically they give rise to diuresis, glucose excretion, and natriuresis. And again, what I mentioned, that they will reduce the preload, they will reduce the afterload, and they will increase the cardiometabolic efficiency. And we'll have a reduction in the blood pressure, systolic by 3 to 5 millimeter, diastolic by 1 to 2 millimeter. There is a reduction in the weight, left ventricular mass is reduced, and there is improvement in the kidney function. Now, they also have favorable effect on the Diffronzo's omnius octet. You know that these are the basically 8 defects which are described by Diffronzo. And you can see the SGLT inhibitors, they have got at least here in the 5 or 6 important defects which have been described by Diffronzo. They work, they improve the beta cell function, they will reduce the glucose secretion by alpha cell, and they will they they have got the glycosuria to give rise to weight loss and improve the insulin sensitivity by increasing the glucose uptake. So the SGLT inhibitors edge over other oral anti-diabetic agents. I have only given the slide on DAPA, but almost the same observation with the other SGLT inhibitors. So this is a class effect action of SGLT inhibitors. You can say as a monotherapy, they can have reduction in HbA1c of 0.89, add on to metformin 0.84. Like otherwise, there is significant, you can say the HbA1c reduction at each and every combination. With they combined with metformin, combined with GLP-1, combined with the sulfonylurea, the D4 inhibitors, or insulin. Then again, the same data is again a data for DABO. The same data is also for the empagliflozin, that you are able to demonstrate durability. This is 4 years data. And it has been shown here that treatment with dapagliflozin results in the similar reduction in HbA1c with other oral anti-diabetic agents. You can see on the left side, the dapagliflozin admitted to metformin, one group, and the other group, the blue one is for the glipizide and metformin. And you can see here that durability of maintaining HbA1c reduction is preserved over 4 years of treatment with DAPA, and the same figure is also available with the empagliflozin also. Then it offers the 10 times lower risk of hypoglycemia. You all know that any SGLT inhibitor alone normally does not give rise to hypoglycemia. And so therefore the incidence of hypoglycemia is very minimal. And here you can see that compared to glipizide and metformin combination, the risk of hypoglycemia is 10 times lower. Now, then there are the beyond glycemic management and beyond glycemic. What is the pleiotype of SGLT inhibitor? You all know that they offer weight reduction and proportion to BMI. If the person is, say, has got, on a C on the right side, if BMI is more than 40, then weight loss reduction is 3.4. But you can say that across all the BMI, you talk about the normal weight or overweight, obese, you have got the weight reduction by SGLT inhibitor. And then again, another benefit of blood pressure reduction is there. This slide is for the DAPA, and here the same figure is almost there with the other SGLT inhibitors. And you can expect a systolic blood pressure loading of around 3 to 5 millimeter of mercury. And this was shown by Dr. Raju that heart failure and left ventricular dysfunction are early and often undetected complication in type 2 diabetes. I have already mentioned that normal left ventricular function was present in this study in 32%, diastolic left ventricular dysfunction is 16%, systolic left ventricular dysfunction was 27%, and both the systolic and diastolic left ventricular dysfunction was present was there in 25% of the patient, though the patient had no evidence of inducible ischemia. And again, you can see on the right side that the heart failure with preserved ejection fraction is there in 23% of these patients, and heart failure with reduced ejection fraction was present in 5%. Now, this is some of the comparison of the two important SGLT2, DAPA-HF and impaired-reduced. And here you can say that the benefit is there in terms of the cardiovascular death events with reduction in the cardiovascular death or hospitalization for heart failure, first hospitalization for the heart failure, renal composite at point and cardiovascular death. And so these are the trials in type 2 diabetes with heart failure. But you can have trials in type 2 diabetes with or without heart failure. And again, you can see that both these SGLT inhibitors, they have significant reduction in the first hospitalization for heart failure and cardiovascular death in patients with prior myocardial infarction. So some of the landmark cardiac outcome trials, you are available this CVD real time, and that has shown that dapagliflozin is associated with reduction in cardiovascular endpoint versus other oral antidiabetic agents and the 4 inhibitors. And you can see here in terms of outcome, the 51% reduction in the all-cause death, 39% reduction in the heart failure, and all-cause death hospitalization for the heart failure reduced was 46%. Now, as for in the CVD real, the SGL2 inhibitor superiority with oral antidiabetic and cardiovascular risk aversion has been established, whether we talk about death or heart failure and failure, you know that all the favors the sodium glucose 2 cotransporter inhibitors. And again, you can see that the SGLT, compare SGLT with the antidiabetic, I have already mentioned that the relative reduction of myocardial infarction was 90%, all-cause death reduction, HHF reduction is 2. In DAPA-HF trial, that the heart failure with ejection fraction that is less than 40% ejection fraction, both with and without diabetes, you can see that there was a benefit in terms of primary endpoint at 24 months, all-cause death at 24 months, and also, of course, the kidney outcome. And so these are the integrated MFTA, these are the key efficacy outcomes. I'm sure you all know is that, and this is the in terms of the outcome, in terms of cardiovascular death, hospitalization for the heart failure, MACE, 40% decrease in eGFR, death from any cause, hospitalization for heart failure, all have favors the use of dapagliflozin as compared to the placebo. And again, in chronic kidney disease, you can see that again in DAPA-CKD trial, primary endpoint was assessed whether it sustained more than 50% eGFR decline or end-stage kidney disease, renal cardiovascular death. And you can see here that DAPA plays an important role in terms of reduction in the primary composite endpoint. There are also benefit in the secondary endpoints, and that means they sustain more than 50% GFR decline in favor of dapagliflozin as compared to the placebo. Always the question is that though we all know that there is no increase in the incidence of urinary infection with the SGLT inhibitors, but if a person has got a history of recurrent UTI, then of course the SGLT inhibitor should not be prescribed. Of course, the more important, the side effect of SGLT inhibitor is genital infection, and this is quite often we see in day-to-day practice, particularly in females, whether they use DAPA or PENA or EMPA, all of them, they have been shown to increase the incidence of fungal infection. So what are the steps to prevent genital infection? I think we should advise good genital hygiene and request the person to go for adequate hydration. And if symptoms of urogenital infection is concerned, very simply you can take the short course of antifungal agent in this patient. So just to summarize, the patient with type 2 diabetes are at high risk of major vascular complication, heart failure, and chronic kidney disease. SGLT inhibitors has positive effect on metabolic risk markers. They reduce HbA1c, weight loss, and systolic blood pressure reduction. The SGLT inhibitors also reduce the maze and progression of chronic kidney disease in patients with type 2 diabetes. And SGLT2 inhibitors is approved for the treatment of heart failure and particularly dapagliflozin reduces ejection fraction. It also reduces the risk of cardiovascular death and hospitalization for the heart failure. The SGLT inhibitors have demonstrated unprecedented reduction in the risk of kidney failure and cardiovascular and renal death in patients with cardiovascular disease. Thank you so much.
Thank you, sir. Now I would like to invite Raju sir again to initiate the panel discussion session. Raju sir.
I think if you have questions in the chat box or there is any audience who wants to share his experience, is most welcome. Otherwise, if Dr. Zargar is here, then it is fine. Otherwise, Dr. Jamal and myself can move forward. So first, I invite questions from the audience, their views, their experiences. Do we have any questions?
So basically, there is no question answer session. There is a panel discussion basically, sir, for the all speakers.
So is Dr. Zargar is not visible? Is he around or has he left?
No, I think he is left.
He has left. He had some work. He has left.
Okay. So today we had a very holistic approach in terms of newer management of diabetes, which Dr. Jamal Ahmed expressed, the upcoming and established role of SGLT2 inhibitors. Dr. Zargar spoke about beta cell preservation and genetic switch in laboratory in disease state from beta cell insulin producing beta cell to glucagon, either way or reversal. I spoke about the vascular insult to diabetes, the upcoming things, how we look at it. And it's very interesting to note that SGLT2 inhibitors, as Dr. Jamal Ahmed has expressed, is a holistic drug which work on two major sites, the heart and the kidney. And as he has shown and getting more and more established, that these drugs are having this cardiorenal benefit in terms of cardiac failure and renal preservation independent of diabetes. And at the same time, they are independent of atherosclerotic burden. Of course, if atherosclerosis is in the background, the yield or the dividend or the outcomes are more pronounced. So they are vascular drug, and we should leave no opportunity to use them in our diabetic patient, irrespective of their glucose control. And what Dr. Ahmed has shown, that they can be used as monotherapy. And in step one, so these are very encouraging, document-based, evidence-based, guideline-directed, newer directions, which we need to practice in our day-to-day clinical work. Dr. Jamal, you want to add on any other thing and impress upon us how you look the future of SGLT2 inhibitor in times to come in diabetes, and what is the uptake of clinicians in terms of clinicians who are practicing general medicine, endocrinologists and cardiologists? What is the way forward, and what is your advice to these three groups, how we take them up more, because evidence is enormous? Dr. Jamal Shah.
Yeah, thank you, sir. I think you have already touched on each and every point. What I will say that one should also know that where you should not use SGLT inhibitors, because this is a fundamental mistake by some of our colleagues here. I simply ask them, please don't use in pregnancy. Do not use in lactating females because we don't have data how much it is sure. And never use in the anybody who is insulinopenic. Otherwise, the person will go into diabetic ketoacidosis. The other thing is what I mentioned, that if somebody has got recurrent UTI, please don't use. Then when you are prescribing the SGLT inhibitors, please do not be 100% dependent on serum creatinine. You must estimate EGFR, which does not take more than 5 seconds. So this is very important because somebody with serum creatinine, and particularly when the duration of diabetes becomes more than 10 years, particularly if somebody has got serum creatinine of 1.4, it is likely that his or her EGFR may be 30 or maybe 20. While you see that somebody has got serum creatinine of 1.4, but if you just calculate EGFR, you'll find that EGFR is more than 50 or 60. So the guidelines are straightforward, and these are some of the things where SGLT inhibitors should not be used. And already just guidelines have mentioned that if somebody has got the established atherosclerotic cardiovascular disease or risk factors or kidney failure or heart failure or albuminuria, that Dr. Raju has also elaborated and narrated the same thing. That's fine. One thing which I also would like to mention, the data are coming now, the use of SGLT inhibitors beyond diabetes. And one data we have already got published, you have seen that in non-diabetic patients, in terms of reduction in the heart failure, reduction in the hospitalization for heart failure, is also evident. The another area which is where the SGLT inhibitors is commonly is underway now, though it has not come by many people, in IgA nephropathy. And you know that one of the important cause of chronic kidney disease after diabetes is this glomerular disease, that's IgA nephropathy, because this is one of the nephropathy which is characterized by proteinuria. And here, therefore, here, the SGLT inhibitors are already being used, and we are getting encouraging result in patients of IgA nephropathy and chronic kidney disease, who most of them, they have got proteinuria, and the benefit is already there. I will not say that you will use in other causes of nephropathy, in other causes of chronic kidney disease, where the proteinuria is basically tubular in nature. There, the drug may not be that effective as compared to glomerular disease. So I think, sir, you have already told everything, and this is data, and one should be, obviously, this is a wonderful drug, a vascular drug, as you rightly pointed out, because I said whether talk about the cardiovascular disease or talk about the chronic kidney disease, most of these patients, they have got proteinuria, and proteinuria is always an indicator of vascular disease in anybody. So if you are able to demonstrate reduction in proteinuria, the benefit has already been, say, established by these some of the landmark studies.
So, Dr. Jamal, there are three groups which come to my mind. One is patient on dialysis, patients of solitary kidney,
Sorry, I just
patients of renal transplant. What is your take on SGLT2 inhibitor, these three population? Let me define my question once more. Number one, that whether it is the population not being studied in the trial, that's why they are out of it, or do you find any genuine reason that it should not be used and it will be physiologically wrong to use them?
No, I think that if you are using in the, say, end-stage renal failure and dialysis patient, as far as the SGLT inhibitor is concerned, now they are, what I mentioned, that they are too important. Yeah. So what I was saying is that, of course, they were not included in trial, one of the reasons. But if you are using in, say, advanced kidney failure, then or somebody is on dialysis, or in the post-transplant patient. Now, if these patients are proteinuric, which I'm sure most of these patients is there you will use benefit and you'll get the benefit, but benefit will not be there in terms of glucosuric action of SGLT inhibitors. You will get benefit in terms of reduction in proteinuria and improvement in the kidney function. So if you are using SGLT inhibitors in these patients, then you must be sure that here I'm not going to demonstrate what is the glycemic control by this. Of course, it will be poor if the GFR is less. But proteinuria benefit is independent of the glycemic status when you are using SGLT inhibitors. I think that is the important thing.
That is very
very
pearl of the
quickly you'll
meeting
get, yeah.
is, yes, pearl of the meeting is what Dr. Ahmed shared with us, that the hypoglycemic effect or the glycemic effects and the vascular effects are independent of each other. And the vascular effects are independent of renal function and can be used and can be derived even in low GFRs. So you talked about IgA nephropathy. As a clinician, how do I know short of biopsy that it is IgA nephropathy? Should I use it? I don't use it. For me, proteinuria is proteinuria. Let me say, very few of our patients, until they are in the company of nephrologist, in physician's chamber, they don't go and undergo biopsy. So are there any clinical tips you want to offer us, how to diagnose it and how to avoid using it? What is your take on it?
I will not be able to answer exactly,
Yeah, because I also don't know the answer. I
left medicine about when I think when I finished my chairmanship at Department of Medicine, then most of the people desire that now you should leave medicine. Though I always loved medicine, I was there for about 20 years in the Department of Medicine. Then I got separated. And then, of course, at that time, the only way to establish the nephropathy as far as etiology is concerned was biopsy.
Yes.
So what I mentioned about IgA nephropathy is 1 or 2 papers are coming, and they have made the diagnosis by kidney biopsy, and then again they have repeated kidney biopsy. Basically, kidney biopsy was done to make a diagnosis of IgA nephropathy. And there they said that this is one of the nephropathy which is of glomerular in origin, where proteinuria is quite often found. So these some of the papers are encouraging, and they have compared the conventional treatment of IgA nephropathy, that addition of SGLT inhibitors becomes better in terms of assessment of prognosis of this.
Thank you. And the good thing which we share with these drugs like GLP-1 receptor analog is another molecule which is talked too much. In coming days, we'll be having semaglutide, subcutaneous and oral, and liraglutide already on board. Many of us are using deliglutide. So the good thing is that these drugs are not competitive to these molecules. They are complementary, additive, and we should not feel which one of them. Of course, cost is the most prohibiting factor in our country, that how we can use these two molecules together. But given an opportunity on the basis of science, these two molecules can comfortably be combined together if the cost is not the issue and patient is educated enough for injectable liraglutide. Once oral semaglutide comes, which doesn't have CV protection level at the moment except the weight loss, probably then things will be easier. So another message is SGLT2 inhibitor should be combined, provided you have an opportunity to combine with GLP-1 receptor analog. You have any advice on this issue, the combination of two drugs?
I'm here. Look at it. So as you rightly said, that there are many of my patients who are taking both, and particularly who are grossly obese, SGLT inhibitors as well as dulaglutide or liraglutide they are using. You rightly that the fear is that probably oral semaglutide is going to replace. The answer is no, because we don't have till date any cardiac benefit of semaglutide. As you rightly said, that only weight loss. So there are many patients, and you have already said that the 40% of diabetic, they have got kidney disease, 40% patient of diabetes, they have got heart failure, 2 to 3 times they have got coronary artery disease. So I don't think that semaglutide is going to replace. It will only be used if somebody is grossly obese. But if the person is having cardiac or renal problem, I think both SGLT inhibitor and GLP receptor will remain there.
Another thing which we keep hearing from people is just last thing, Neeraj.
Sir,
Like
yes, sir, we have a question from viewers for
yes.
Jamal sir. Sir,
Yes.
how clinically insulopenic is diagnosed?
You see, anybody who is lean and thin, if a person has got diabetes duration of more than 30 years, more than 10 years, and if the person is grossly symptomatic for osmosis, that means he have got more frequency of urination and weight loss, I think clinical make very quickly diagnose. You see, anybody who looks thin, very simple, whose BMI is say less than 19, be very careful not to prescribe SGLT. It doesn't make any difference, any difficult to make a diagnosis that this particular person is insulopenic or not insulopenic. आप जैसे किसी को कहते हो कौन आदमी मोटा है, जो दिखने में मोटा लगता है वो मोटा है. आप किसी डेफिनेशन में फिट करिए, will also say that you are obese because you look obese. So similarly, if you see any thin person who is symptomatic, probably he is an insulopenic.
Sir, and one more question, sir. Any contradiction with elderly or a patient who is suffering from diabetic since last 10 years with SGLT2 inhibitors?
I don't think there is any contraindication, but you have to look certain points. We are using SGLT inhibitors in the people who are 70 years plus, but you have to see certain points. One, that they have got various comorbid conditions, and most of the time they have got long-standing diabetes. And so here, if you are using SGLT inhibitors, make sure that the person is not taking diuretic also, because he is prone to develop dehydration and other problems there. So be careful and see whether the person is not taking many of the drugs and he don't have many comorbid conditions. And if you think that he is taking diuretics, so gradually you have to withdraw diuretic, and then you can put the patient on SGLT inhibitors. Otherwise, this will further give rise to dehydration and many problems.
I'll say just things, couple of things. Euvolemia, you have to ensure the patient should not be dehydrated, what Dr. Jamal is saying. You have to think that patient is metabolically stable, not acidotic, having intercurrent illness. And that's why the usage of SGLT2 inhibitor in acute setting is with lots and lots of caution. So once the patient becomes metabolically stable, euvolemic, and then recurrent UTI, as he described, these are the situations where one should be used. The problem is drug is so safe that we forget often these riders in its usage. So it's not like distilled water, you can use it everywhere. You have to be cautious, apply your mind that your patient, as Dr. Jamal said, the diuretic dose should be again looked at, whether you need this much of diuretic, because by virtue of their glycosuric effect, they will produce osmotic diuresis. So the diuretic usage, in fact, there are studies, SCARS study, which talks about a nighttime better control in blood pressure if you give SGLT2 inhibitors. They are like moderate dosage of hydrochlorothiazides. So, the riders he has spoken should be taken into consideration regarding the patient profile, and it should not be a blind usage. No medicine you can use blindly. You have to apply your clinical acumen and wisdom that who are my patient who will derive maximum benefit vis-a-vis who are my patient who will be harmed by this. And as if I'm right, Aristotle said, primum non nocere, don't harm So clinicians, we have to be very judicious in using our drugs. Dr. Zamal, you want to say anything in
No,
last
sir, I
couple of...
mentioned, I already said that, you see, the best physician is one who learns in his life what not to do.
Yes,
So,
very powerful thing to learn and to say, like my teachers used to say, a good surgeon is one when not to operate. And Dr. Jamal has made it still more wiser by saying that you should, each day you should learn when not to work, not to intervene. Nature is superior healer than we as human beings, and understand the nature. The more nature you understand, more judicious action we will take. So as we grow wiser, we feel that nature is a bigger player than us. And I'll request Dr. Jamal to participate in that discussion, that today I feel I am far more wiser than when I was a fresh with knowledge, say 30 years back. And that is the effect of learning, clinical learning, that each day we learn when to go slow. And when you come out of institution, you learn aggression. So clinical medicine make you more balanced, that your action has to be appropriate, adequate, justified, and never you should do harm to the patient.
true, sir, rightly said.
Dr. Neeraj, I think, Mr. Neeraj, we can call it a day, and it was wonderful learning from my two colleagues on the panel. And I'm sure our audience was equally benefited by the deliberations on management of SGLT2 inhibitor, SGLT2 inhibitor management of diabetes, beta cell preservation, and I threw some light on newer perspective on vascular injury in diabetes. Thank you very much, and I must thank HiGlance for providing
Sir,
this
on behalf of,
opportunity on Sunday afternoon
sir, on
to
behalf
meet
of,
all of you. Hope to see you again.
yes, sir. On behalf of HiGlance, I, Dr. Neeraj, would like to express my gratitude to all of you for your cooperation, which has enabled us to conduct a highly fruitful webinar. Thank you, all doctors who gave their valuable time for this webinar. We are thankful for the support you all given to HiGlance product. I would like to express my special gratitude to Dr. Zagar sir, Dr. Zamal sir, and Dr. Raju sir. Thank you, sir, for the informative and interesting talk on diabetes. Thank you, sir. Thank you very much.
Thank you so much.
Thank you, sir.